At the very outset, I would like to thank SAGES for giving us this opportunity to present our work titled The Effect of Diabetes Mellitus on Postoperative Outcomes of Sleeve Gastrectomy and Gastric Bypass. We have no disclosures to report. To kick off things, bariatric surgery is the only therapeutic modality proven to produce long-term weight loss and reduce associated comorbidity in morbidly obese patients. Preoperative diabetes mellitus is a well-known risk factor for poor outcomes following general surgical procedures. With the recent impetus to perform these procedures more often in patients with diabetes mellitus, the numbers of such procedures has been rising. Thus, we wanted to investigate the impact of preoperative diabetes mellitus on postoperative outcomes following minimally invasive sleeve gastrectomy and gastric bypass. We used the MBSA-equipped database from 2015 to 17, and appropriate CPT codes were identified to choose the procedures of choice. The patients were then classified into non-insulin dependent diabetes and insulin dependent diabetes mellitus. 30-day postoperative outcomes were compared amongst the groups, and the statistical analysis performed. In all, we analyzed about 116,000 patients, predominant of which were patients who underwent sleeve gastrectomy and were non-insulin dependent, which were assumed to be the low-risk groups and were considered as a reference for multivariate analysis. Patient demographics showed that patients who underwent gastric bypass and were insulin dependent had a higher ASA classification and more comorbidities as shown here. Multivariate analysis with the reference group, that is the patients with sleeve gastrectomy and who are non-insulin dependent, showed a significant increase in postoperative complications in the patients who were insulin dependent undergoing a gastric bypass as shown here, including both fatal and non-fatal complications. 30-day postoperative outcomes further showed that there was a high increase in 30-day mortality up to 2 times the reference group in patients with insulin-dependent diabetes undergoing a gastric bypass. The limitations of this study were essentially the unclear nature of control and severity of the diabetes that the patients were having, namely the home insulin dose, the type of insulin, the type of anti-diabetic treatment, and their preoperative HbA1c were not available to us to analyze. In conclusion, patients with insulin-dependent diabetes mellitus undergoing a laparoscopic gastric bypass are at a significantly elevated risk of overall 30-day mortality. Thus, emphasis on adequate preoperative counseling about the risks and possible medical optimization in these patients before elective surgery such as a gastric bypass is imperative. In addition, there should be an early index of suspicion for significantly elevated postoperative complications in this particular cohort when patients get admitted to the floor after their surgery. Thus, I would like to conclude my presentation. Thank you.